rid of them. And the biggest way that we undermine resilience is by telling people that their brain is broken and their problems are due, that it's a biologically based mental illness, which means that you can't control it. It's out of your control, no different than cancer is out of your control. And I'm convinced that that actually is seen as a benefit by doctors in the pharmaceutical industry, because that keeps people coming back. And now I'm back to the two worldviews. That is the worst thing for me that I would want my client to think, that they are unable to control the problem and that they can't successfully deal with it and move forward in life without having to rely on, an external thing to help them through it. But psychiatrists don't want people generally to think that. They want people to be dependent on the medication, like insulin for diabetes. I want to come back to a term that you used, which I've changed the way that I think about this term: coping. I no longer like that word.
Interesting.
And the reason why is that every time that I hear coping, it's always in the service of a coping strategy used to get rid of or suppress or control unwanted internal experiences. And, clients come into therapy often, can you teach me some coping strategies for getting rid of my anxiety? And so then we have the discussion of what's the opposite of trying to cope your anxiety way? That would be accepting it, being willing to have it. And one of the ideas that I try to impart in therapy is that the problem isn't that you don't have the right coping strategies. The problem is your belief that you need coping strategies to begin with. And so I would rather have people, I was saying on my website, see if I can remember it, life is meant to be lived, not coped with.
All right, so I have another perspective on this.
Yeah.
And one of my mentors in my doctoral program, actually, she self-identified as an expert in coping.
Mm-hmm.
Now, the way you described coping, I would argue that those are generally maladaptive coping strategies. Mm-hmm. There are ways to, if coping is the way that you react to something that's challenging, right? They can either enhance your experience, lead you to overcome it. They're really valuable. They're aligned with your values, or they can be harmful. So my dissertation research was examining the coping strategies of adolescent females who had eating disorders. So I had a clinical group. They were in a hospital-based setting who were diagnosed with either anorexia or bulimia, and it was severe enough that required hospitalization or partial hospitalization. And I compared it to a non-clinical control group, a group of same-aged peers who had no history in the mental health system. And we created these like hypothetical vignettes of social problems, right? So one example of them was homecoming is on Friday night. You go to lunch, you're sitting down with a group of friends, and they're all talking about going to a party after the homecoming dance at your best friend's house, and you weren't invited. And so that's the dilemma, right? So there's a lot of uncertainty. And then it's asking these questions. Why do you think this happened? So now it's your cognitive appraisal of the event. How will this make you feel? And also rating it. So the emotions and then the intensity of it. And what would you do about it? And so you see this clinical group of these girls would widely recognize it as what's called a hostile intent attribution. So I must have done something. She doesn't want me there, right? Mm-hmm. I wasn't invited. What are the emotions? Negative, intense. They could be shame, sadness. And then it's, what do you do about it? And there was, for the girls who were in the hospital program, it's an avoidant coping strategy, but there's something called intrapunitive avoidance, where you actually punish yourself. You hurt yourself. Could be cutting. You could be restricting food. You could binge and purge. So you're avoiding dealing with the entire situation. You're escaping that emotion. That's all coping. Okay. But obviously it doesn't serve that person. It interferes. And it's probably a maintaining factor in why they're struggling with an eating disorder. Now, I compare this to the other group. And the same age peers who don't have these same mental health difficulties accept certain things to possibly be true. Well, I didn't get the invitation yet. I don't have to be invited. I'm her best friend.
Mhm.
So the intent attribution isn't necessarily hostile. They're open to the possibility it could be another reason, but they don't attach to it as true. So their emotional reaction is less, and it's not as negative. But here's the key point to this. What do you do about it? I would go talk to her. You're exposing yourself to it. You're facing and solving a problem. You're not relying on the illusion your mind creates about it. You're going right. That's an approach coping problem solving strategy. It
Mhm.
changes the entire outcome of that person's existence.
Right.
So that's why I think coping is so incredibly valuable, but understanding what is coping that is serves a person's values, that helps them overcome the problems that exist. And so you're describing a coping mechanism that's escape oriented, right? Get me out of this situation as if that's effective, right? And I think a lot of people have to learn it. And so if I'm a cognitive behavioral therapist and I'm working with an eating disorder and I'm conceptualizing, I'm saying that this eating disorder potentially is an intrapunitive coping mechanism that represents some legitimate deficits. So what's my treatment going to be? What's my therapy? It's going to be action oriented. I'm going to get them to do those things. I'm going to get them to face those problems. I'm going to help them to do this differently because now you're not stuck in your head in this story where everyone hates you and no one wants to be around you because your perceptions become your reality. We are creators of our reality. That's kind of stoicism right there. Right. And now I'm trying to build this person to face their life.
Mhm.
Okay.
The
You might
way,
find out you did something wrong, but
yeah,
now you have that opportunity to also solve it. So do you see
right.
the distinction?
I totally do. I get the distinction between adaptive and maladaptive coping, and that was a really good point. I was reflecting as you were talking. Why am I annoyed by the word coping? Because I feel like it's more than what I have mentioned. And here's what I connect it to: um, the notion that therapy involves techniques, and this is I think the common way that therapy is delivered based on the kind of superficial formulation. Um, Therapists say to the client, well, okay, so you have an anxiety issue. I'm going to share some techniques that you can use to manage that, and they're usually the coping away your unwanted experiences variety. But I don't think of what I do as a collection of techniques, and I'm sure you don't either. I think of it as an approach to living life. And I guess I also have an aversion to the notion of techniques,
Yeah.
and it's this common metaphor that as a therapist, you're like a carpenter and you have a tool belt and you pull out a tool for the right problem. Um, but a tool isn't a formulation based overall approach to moving forward and living life. And I think coping often gets wrapped up in that. But yep, I take your point. Really good points. Can I ask you a question?
Yeah.
We were talking about the various harms of therapy, and I have to go back to the late great Scott Lilienfeld, who wrote really eloquently about this, about 3 ways that therapy can cause harm. There's direct harm, like critical incident stress debriefing. There's opportunity cost, and I want to hit on the third one and ask you about your experience with this. The third one is reducing the credibility of the profession.
Mm.
And I think both you and I believe that we have um, something special to offer that is legitimate and based in science and based in sound philosophy that can transform people's lives for the better. And it's credible and it's ethical and it's helpful. And we've both seen countless instances of clients seeing other therapists and getting something that's just kind of ridiculous. And I can think of one example where in Wollongong, Australia, where I used to live, there's a practice that specializes in walking therapy. Every session involves walking. And little known fact, the Medicare rebate that clients can get from the government is $20 more per session if you leave the office. So this practice figured out that they can charge clients $20 more a session by walking. And I had an anxious client come to see me, and her therapist took her to the beach and had her dunk her head in the water while walking. And this evokes something called the dive response, which is meant to be a way of kind of resetting your mind when anxious. And the client thought that was ridiculous and didn't return to the therapist and came to see me. And I sort of shook my head at, once again, another example of practice that kind of gives our profession a black eye. And that rubs off on me. Clients who have that kind of experience think, well, why should I bother to see a therapist at all? They don't know what they're talking about. What's your experience with that?
Yeah, what I find is that there's often the misunderstanding of interventions that are misapplied to the wrong person at the wrong time. So it's interesting because I have a full model dialectical behavior therapy program here. And DBT is a pretty efficacious treatment and a lot of value to it. Like we've seen it really change lives. And there are skills that they learn, but it's applied to a specific person in a certain situation. So those clients have such severe emotion dysregulation and difficulties tolerating distress that they remain in active episodes of self-harm and potentially substance abuse or eating disorders or chronic suicidality. And there is the theory that drives that is they have to learn how to tolerate distress and regulate intense emotions to first change those behaviors, because they just keep you in a cycle of self-harm and don't allow you then to create that life and face the things you really need to face, because let's face it, those behaviors are used to escape. And I think what research shows is that they need something to turn to in the most difficult of moments. And that's why we have coaching, and I provide coaching. So the use of the dive reflex to reduce the intensity of the emotion is for somebody who's about to kill themselves or is in such intense emotional pain, they got a knife up to their arm and you're talking to them on the phone because they only know how to self-regulate through that cutting. And now you're going to say, okay, I'm going to get you to step back. Let's just go get some ice. We're going to dunk your head in there, which is going to lower your heart rate. And it's going to reduce the intensity of the emotion, maybe not dramatically, maybe from a 10 to a 7. And now we can kind of problem solve what's next. So it's not a strategy to change the way you feel necessarily. It buys time. It allows someone to now stop and think about what the next step is. And it's not an intervention for an anxiety disorder. It might be an intervention to get you to stop and do something different instead of cutting yourself, to maybe kind of refocus. But I don't use it. I don't dunk my head in water because I don't face that problem. So there are some interventions that are valuable for a specific population in a specific time of their lives to stop something. And then if you take it outside of that and you apply it to just a way of being, right? Like, oh, I don't like how I'm feeling, let me get rid of it, then it actually does harm. And I think that's, to your point, is that we can actually misapply concepts in the wrong situation and create harm. And that's sort of the value of there has to be some credible way of evaluating what we're doing under some philosophy or theory that's grounded in a reasonable understanding of people who are flourishing and the human condition and our own historical understanding of how we overcome stress and difficult conditions. So the credibility of our profession is really at risk because there's so much pseudoscience and there's so much nonsense, and it's become so commercialized and it's become so connected to popular culture that people learn from TikTok, and then they come into your session and they have an idea what it means to be mentally healthy, and they're not talking about things in terms of diagnoses. Well, tell me about yourself. Why you're here? Well, I have OCD, ADHD. I'm on the autism spectrum, borderline personality disorder, and bipolar disorder. What? Like that's how some people describe themselves, and so that is harm, right? That's negatively influenced the credibility of our profession because there's no path to being well with identifying yourself in that way?
I just piggybacking off your last point, I can't help but think that nowadays there's what's the opposite of stigma? Like social capital in being mentally ill and identifying with mental disorder diagnoses.
Yeah.
Like you actually get attention and validation for being mentally ill at the same time that identifying with these diagnoses might disempower you and foster the lack of resilience, which are negative. People are embracing these labels because of the social capital that they bring, which I guess doesn't give me a lot of optimism that this is going to change anytime soon.
Brett, I'm actually in a little bit of a crisis of confidence and questioning what I want to do next, because I'm finding it much harder to work with younger people who are coming in who don't want to lose their diagnoses. They're actually not really even coming in for change. They're coming in for validation. And I don't, it's harder for me to work with it because the perspective that we're sharing, which I think at another point in time would be really understood and even valued, because I think the intention of going to see a psychologist was I want my life to be better, has shifted, where people are coming into therapy wanting validation that they're ill. And they actually just believe I need to be in therapy because that is justification and validation of my condition. There's no real intentionality of overcoming it. And they see these conditions as if they're immutable characteristics that they'll deal with the rest of their lives.
So what are they looking for from you in that context?
I think it's validation, support.
Beyond validation, though, but like what is the therapy meant to look like?
That's where they get stuck. And I don't think the TikTok reels take them through that.
Okay.
And so, I don't start therapy unless there's an agreement on goals.
Yeah.
And I don't start therapy unless there's a collaborative understanding of what the problems are. And so I've lost a little more, I've just lost clients. I've just agreed, like, I'm not the person to be working with you because this is what I believe, or this is what I think your potential is. And it doesn't mean I don't get into some critical conversations about how they've adopted that mentality, but there is a resistance to what I'm saying.
Interesting. Okay. I'm sure you've found what I have, which is in cases where you are able to share the alternative perspective and the person is receptive to it, they often end up being profoundly grateful that you've been able to take them out of that old mindset. And we could have a whole other conversation about what I'm about to say now, but often a problem with that is when you do that, you are now directly contradicting what their doctor told them. And you are actively working with them and their doctor. And the doctor said, you have a broken brain and a chemical imbalance, and this is like insulin for diabetes for you.
Yeah.
And now you're thinking that's all the exact opposite of what is true. And I really need to rescue my client from believing in that, that dehumanizing and unhelpful mindset.
I'm really good at that. Really good at that. Yeah. You know what I find?
What?
In my, I don't know, I can probably look at the last 5 or 6 years. I can recall only one psychiatrist who refused and debated on me and refused to collaborate with me.